Great. So here we go. This is our speaker today, and I'm just thrilled to introduce Dr. Kari Stephens. She is the Vice Chair of Research at the Helen D. Cohen Endowed Professor, Director of Clinical Research Informatics, and Professor in Family Medicine and Adjunct Professor in Biomedical Informatics and Medical Education at the University of Washington School of Medicine. Dr. Stephens conducts research focused on health equity, integrated behavioral health, chronic pain, PTSD, anxiety, depression, substance use, cancer, long COVID, and informatics data sharing, particularly in the primary care setting. Dr. Stephens is a practicing clinical psychologist, currently treats patients in primary care integrated behavioral health care settings, and attends as a core panel member of the Psychiatric Addiction Conference. So with that, I am thrilled to turn it over to our speaker today, Dr. Stephens.
Thank you very much, Dr. Felker. I am very excited to be here, everybody. I have many brethren here who are behavioral health providers as well, and many more. What a group. So fun to see in the chat the geographies y'all are coming from. And hopefully I can be of help to you all today. That's my goal, is to offer some information that can help you do even better things than you already do for all of your patients. So you can see the title up here, the sort of standard digital behavioral health therapeutics piece, but the fun part of this is, really, is there an app for that? And can AI be your next therapist? There's a lot going on in the world right now, making us wonder about that quite a bit. So let me jump in and say the learning objectives that I have for us all are first to give you some background on where I come from in primary care and integrated behavioral health, and sort of what inspires me to think about our clinical care settings for where we can have the most population reach for folks. And then the second piece, as we look at that setting of where we're really trying to deliver that care, why I've kind of come into the space of digital apps and how these could help our patients, but also how we could disseminate care and really advance integrated behavioral health and just do good things with all this tech that's emerging. So I'm not a massive expert in all of this, but I've definitely been delving in and dabbling in many ways. And so I hope that I can share out what I've been learning in a way that you all feel that you've gained something from this by the end too. So like I said, I want to start with integrated behavioral health in general. For those of you who don't know that term, it's really the notion of how we embed behavioral health providers into primary care. This is an evolving space, and we have a workforce that's struggling that I'm going to get into a bit more. First, let me just back up and say, many of you have probably heard this already, but patients accessing healthcare is not something we see when it comes to mental health in a very large population reach kind of a way. In other words, most don't. And you can see some of the statistics here down the left side column of just where the giant gaps are in terms of sheer number of folks that don't get access to mental health care. And the areas that we really need to be focused on is just initially in accessing and navigating care, but also in how we can diagnose people, have referral pathways to really get into special services as needed, and also deliver universal just behavioral wellness interventions to help with as much as we can with prevention and quality of life for those that are suffering. And then, of course, enhance our efficiency in how we do all of this and our expertise. So we have a lot of problems in terms of really having reach and meeting the need of our populations and communities out there. Probably not news to you all. One of the major models that has been established in the literature, the evidence base, and has been doing lots of work to try to disseminate is the collaborative care model that grew out of the University of Washington's psychiatry department. It's called collaborative care. And this is a model that I've been exposed to and helped work with through the AIM Center for many years. I used to be faculty in psychiatry and behavioral sciences here at UW before I moved over to family medicine. And so for those of you that don't know this model, this is generally a team-based approach within primary care that involves 4 key people, where the patient is the key member of the whole team and then is surrounded by 3 different folks coming from different perspectives. One is, of course, the primary care provider that's managing care for the patient in that primary care clinic. The other is the behavioral health provider, and our BHPs, or behavioral health providers in collaborative care, come from all different kinds of backgrounds. They can be social workers, nurses, psychologists, various kinds of master's level folks, generally somebody who has a clinical role of some kind, but that can help manage a panel of patients to ensure that we can give some brief evidence-based psychotherapeutic care, some care management, and then also work in partnership with the fourth team member, which is the psychiatric prescribing consultant. And sometimes that's a psychiatrist, sometimes that's a psychiatric ARNP, somebody with expertise that also can help feed information, do case reviews, and help support the overall team with care management, treatment trajectories for those patients. So in that particular model, on the left, you see the kind of measurement-based care and case management tracking that we tend to do in that. And on the right side, this was a graph that I made years ago when working with the AIMS Center, where I asked a bunch of care managers that I was in the midst of training to give me feedback on how many different strategies were they trying with each individual patient they were presenting as a case in the learning environment that I had them in, trying to teach evidence-based behavioral skills to them. So at the bottom, you see an x-axis of the number of intervention strategies each behavioral health provider tried, anywhere from 1 to 7. That's a lot for those. And you can see most of them were 4 or more overall. And then I color coded this based on how many did they say they felt were effective, doing something good for the patient. And what's really alarming with this, and I think just a visualization sometimes speaks 1,000 words, where you look at the dark blue, that's 0. So you're looking at a workforce that's saying they're trying a ton of things with patients and they're not working. So, I would venture to say this is still true today, where a lot of us are feeling the challenge of trying to bring evidence-based skills to bear with our patients and struggling with really a lot of complexities and multiple morbidities. Training in behavioral health providers has been a big focus of some of my time in the past. We published a book a while back in 2016 that was integrated care. We call it our glorified pamphlet. Anna Ratzliff and I worked closely together on sort of seeding and creating this idea. And Jürgen Unitzer and Wayne Caton were wonderful co-editors with us in putting together a bunch of chapters that are really just pragmatic tips on how you do integrated behavioral health across various different problem spaces in primary care. And then we moved to putting a bunch of different modules up for people. That these are free. They're now hosted instead of on the MHTTC website on YouTube in various ways. I put an example of a link for one of these there. It's pretty easy to find if you want to take a few minutes and watch how we adapt some of the use of these types of skills you see on the screen. These are all different strategies we've taken to try to help educate the workforce to attack some of those problems. And I'm going to continue and give you guys just kind of a litany to bring you into where do digital therapeutics kind of fall when it comes to trying to get into this space. So here you see a paper that several of us put together that showcases that the co-location of a behavioral health provider into primary care settings, when we surveyed family medicine physicians coming in, getting their board certification renewed across the country. So we have 100% response rate to this survey because they're in the midst of clicking through the American Academy of Family Physicians process to get boarded. So that's a really great way to capture some data from those folks. And you can see that it's proliferating across the country, but not necessarily evenly across states. And it's increasing year to year to the point where we've now got close to half, if not the majority, since these data were actually looked at with family physicians saying they actually work side by side with some type of behavioral health provider. And that can vary from various different masters and doctorate level folks from both the medical and the behavioral and psychological side of the world and social work, et cetera. So that's exciting to see. What's not so exciting to see, we also did a study where we looked at burnout amongst primary care folks. And this was part of a big PCORI funded study where we looked at 42 different practices, and we asked everybody in those practices to voluntarily answer an anonymous survey about their burnout level. And we were able to divide that by type. And the really sad news is if you look down that left side column, you'll see all those numbers are pretty darn high. So the majority, regardless of the role in the clinic, are suffering from pretty significant levels of depersonalization, emotional exhaustion, and personal accomplishment, which are all parts of a pretty well-used burnout scale that's got some pretty great psychometric properties to it. So this is really a problem. We have a workforce that's very much struggling in the primary care backbone of our healthcare system workforce. There's also, as many of you know, I'm preaching to the choir, I think, there's a shortage in behavioral health workforce across. And this is just a paper that I wanted to, or HRSA actually, website, where you can see sort of the latest, at least from 2022. And I don't think the numbers are changing that drastically in the last couple of years, especially when you look at rural counties versus urban counties. There is a lack of and a shortage of behavioral health workforce overall in both of those settings, but even more drastically in rural counties for all of those that are coming from those communities. Thank you for being here and thank you for the work you do. It's really difficult that we have so much shortage going on. Turnover and well-being and burnout are all problem spaces as well in this limited workforce. And so, I promise I'm not going to be just Debbie Downer this whole time, but I think it's really important to look at context of these things. And in 2024, what you can see here is that the mental health wave is only increasing in its crescendo in the pandemic. So this is also really disturbing. So now, how you've seen me lay this out is people have a lot of difficulty accessing care. We have some reach potential in primary care, but we have a workforce that's fairly burned out and a shortage of people doing it. And we've got a wave now of mental health. And this is in addition to the chronic condition wave that we all know is also occurring. Happy news is that you can see, and this is a study that my team didn't do, but another group that shows that there are some cool trends in community health clinics in terms of showcasing that team effectiveness is perceived as really improving provider experience, helping reduce burnout, and helping increase providers' intent to stay in what they're doing. So those light blue boxes that you see on the screen are showcasing to you that when team work is happening, team effectiveness and integrated behavioral health is a really great and common now, I'm happy to say, example of team-based care and primary care is on the higher side. You can see how those three outcomes tend to improve, and provider burnout goes down. That's in the middle. Provider experience, in terms of having a good experience within their job increases quite a bit, and their intent to stay increases quite a bit. So all of this points to we really need to work in this space and continue to help make sure that we can support team-based care as much as possible. One of the other difficulties we've been having is disseminating this kind of model in an effective way across all of primary care. We've known for quite a while that doing integrated behavioral health is efficacious. We've known it works. It does a lot of really good things. So why aren't all these practices doing it? One of the hurdles is that we come to them often with ways to do that from the science side that are very prescriptive. You do this and this and this, you set it up that way, and folks are having difficulty doing that. I like to say, if you've seen one primary care practice, you've seen one primary care practice. And I think of it akin to the same way we don't tell our patients you need to have chicken and broccoli and rice. We might say you need a protein, you need vegetable, you need some kind of a carb. And then it's up to them how to do it. And I think we need to think of ways we can do that with primary care practices that have their own ways of operating. They have really unbelievable, innovative ways to think about how they can change their practices, and they need some freedom and help to know how they can engage in increasing integrated behavioral health in that sort of approach. So one way to think about that that we've been working on is there is a cross-model quality of care framework that got published. This was in the 1980s. Why, don't invent a new wheel when you've got one that's working, that Donna Bedian published a long time ago. It's very simple, you guys. It's really that you have structures within a health clinic, and then you have processes as well that you see examples of here, and those two things lead to the positive health outcomes. So one of the things that we did is published core processes and structures paper that really lays out an integrated behavioral health framework that cross-cuts all the different kinds of models out there around integrated behavioral health, including collaborative care and several others, and talked with national experts across the country that have led those different models, and we used a mixed methods approach. And what you see here are the 25 processes and 9 structures. I just wanted to give you a quick visual definition of what it is when we say we want to increase integrated behavioral health, that this is what looks and smells like integrated behavioral health in the way that we found consensus in a really concrete way. And our time is short, so I'm just giving you a smattering, and I'm not going to go in detail through all of these. But we also did a large trial that we just completed, and I think it's probably the largest funded trial of trying to improve integrated behavioral health in primary care ever funded. This was through PCORI. It was $18.5 million, and these 42 practices I mentioned. It was testing an intervention that really comes at it from a practice-centric perspective, where we used quality improvement and lean-based intervention approaches, lean coming out of Japan, the way that Toyota invented that as a strategy, for example, to do change management and really improve integrated behavioral health through a structured way, but that was practice-centric, was so that primary care clinic could really look themselves at what they need to do and how they could do it to improve integrated behavioral health. So we were really trying to test this hypothesis that if they complete more stages in that intervention that we developed, compared to a treatment as usual, compared to a randomized group of other clinics that didn't get the intervention, that they would have higher levels of integration overall. So we just published this paper. It came out last month that actually showcased in a very happy news way that across these different clinics that you see nationally located across the country, that were all getting this intervention between 2020 and just as the pandemic started in early 2017 until the pandemic started in early 2020. And we were really targeting patients with multiple chronic conditions. I'm about to tell you what we found. And you can see, but I just first want to make sure you're sort of grounded in who we were targeting. These were patients with multiple chronic conditions. So they either had a behavioral health / mental health condition plus a chronic medical condition, or they had 3 or more chronic medical conditions. And so many of you out there who are working in primary care space in behavioral health, as a psychologist who works in primary care myself, we're dealing with all kinds of problems in addition to mental health that can include diabetes, obesity, insomnia. The list goes on of ways in which we have some evidence-based for behavioral interventions. This is what we saw in the population that we pulled in this intent to treat study. Over 80% of them had chronic pain. I do a lot of work in chronic pain. Some clinics actually see up to 50% of their total visits in a day to a primary care provider involve patients that have some kind of chronic pain. It's just a massive issue in primary care. But lots of depression, hypertension, diabetes, arthritis, anxiety, just to kind of name the top few that you see here. And most of these patients had more than 4 of these types of conditions. What we found is that the intervention worked. So that's the good news. I'm not going to go a ton into that particular study, but I'm just giving you guys this feel of here's what's sort of happening right now in the primary care space. If the way to read this is in this trial, that black bar, any of these lines that you see not crossing the black bar means that those were significantly improved. And so the practice integration profile is a self-reported measure of integrated behavioral health. That's what this particular outcome is representing. And it's very exciting to see that a practice-centric way of improving integration worked for our practices. So if we kind of step back for a second and look at, so we've got these workforce challenges and we need to come at this from a practice-centric way. We now have this wave of technology that's also coming and hitting us at this point. And so how do we look at digital behavioral apps and how they fit? This really, in my mind, you guys, is inspired by what we call user-centered design, human-centered design and engineering, UX. If any of those terms are familiar to you all, it's really been an incredible methodology that campuses now teach all over the country, and how to use that. Tech companies use it all the time. It's a methodology to how do you develop, for example, technology solutions that are user-centric. And so, in other words, part of what that method does is it talks about you need to understand where you're trying to put change into. Go empathize with those quote unquote users. So I think of primary care practices, I think of all of us as providers as the users. We're the ones who need to figure out to some degree how to look at these behavioral apps in practice for us. So obviously patients are users of the actual apps, but we are also purveyors of asking our patients to potentially use these things. And so I kind of want to put your head there of this is where we're coming from and thinking about this. So I've gotten interested in trying to look at some of the efficacy and utility of some of these kinds of apps. And I'm just giving you an example of a small trial that we finished recently that's about looking at a digital behavioral app that's meant to help improve quality of life for patients with chronic pain. And it's embedding lots of evidence-based principles of acceptance and commitment and cognitive behavioral therapy into the app itself as a standalone to see if that can potentially help improve quality of life for patients that we pulled out of primary care settings getting treated for chronic pain, to improve on a well-validated scale of pain interference in their life. So the good news about that work recently, and this is nascent and we're still working to publish this overall, but we did present these preliminary findings at the American Psychological Association conference last summer. And you can see that in that green box, we're using a scale that's called the pain interference scale through the PROMIS measures that are out there. So if you're not familiar with that, a 2-point change on that scale, and we're looking for a reduction, so you're looking for negative numbers here, is a meaningful difference, a meaningful potential improvement. And so what I'm able to show you here is that in this very small study that was not completely sized, we had an N of about between 90 and 100 patients. We did find a difference there at the 1 month. So, and that's generally when people tend to use apps, and it dropped by 2 points, but it didn't necessarily hold. So the title I've got up here is, potentially faster than office-based psychotherapy. I'd say I feel like I'm a pretty good pain psychologist, you guys, but I don't know that on average I could get every patient that walks in my door better on average in a significant drop in only a month. So that's pretty cool if that actually could stick and work, or at the very least potentially be an augment for the work that we all do now. That's sort of where my thinking is going. So I wanted to just give you that example of a kind of a study that's being done out there looking at these. And now I'm going to kind of jump into the informational side of things. So you've gotten the background, you've sort of seen the landscape of what's going on in primary care around this, and then seeing how this tech is all emerging. And I think now to sort of make sense of this spaghetti bowl that we've got of all these different things, I'm going to teach some terminology to you all so that you hopefully feel more facile in the market out there of all of these types of apps and software solutions. So there is a notion of digital health. That's something that engages users with health-related content through this digital user-centered design or health data collection approach. And it doesn't require regulatory oversight. So if you see things that tout themselves as digital health, that's not necessarily anything with oversight. Then there's digital medicine or medical devices, and those are potentially evidence-based softwares and or hardware that measure human health or deliver evidence-based content in some way, and the regulatory oversight for those things can vary. Then there are digital therapeutics. That's a very specific term that's about products delivering evidence-based interventions to prevent or treat disease. And those require efficacy kinds of studies, showcasing that there's actual evidence that they work. And then safety features need to be addressed clearly, and that as a function of those specific intended uses. And those are the things that get regulated. So as I keep going here with sort of vocabulary, what you see here are 3 boxes. There's sort of 3 types of these things that we see out in the world. There's digital diagnostics and therapeutics that are FDA regulated here in the United States. And I really want to emphasize for us all that that's a bucket we definitely want to be watching as licensed clinicians that interact with patients to sort of help educate them around what possibilities are, but also be thinking about in our own practices how this might fit as treatments that we might want to help push towards folks. So digital diagnostics and therapeutics is a specific term that the FDA regulates and stamps onto software that's being conceptualized by the FDA as a device. About over half of those are mental health related at this point. So we happen to be in that space for those of us in mental health care where lots of this is emerging quickly. There are others related to also common behavioral health kinds of issues like insomnia and chronic pain and more in that space as well. So I think there's just huge play for us to really be interested and curious about this space and starting to plan for how we can land these kinds of potential options for treatment with our patients. The second big bucket, and this is probably the majority of what you see out there for those things that we might all feel are somewhat legit or even used ourselves, and that's health and wellness apps. And these are really use at your own risk kinds of products, right? So these are direct to consumer marketed types of things. I put in that box the Calm app, many of us are familiar with, that help us with mindfulness, relaxation in various ways. These are not necessarily meant to be specific treatment, and they're not necessarily evidence-based, although certainly many of them stumble across and use those kinds of things as well. And really, a lot of the for-profit companies that are building these tools are really excited about this box because direct to consumer to them often equates to making more money quicker than trying to go through FDA and having payers pay for things. Then there's a third bucket that are these entertainment apps. And there's a lot of questions right now about whether these entertainment type apps are causing harm. So these are not necessarily apps that are meant to push wellness per se, but we're seeing things like, TikTok being at risk for being shut down. I want to highlight we're seeing a lot of chatbots out there, AI, artificial intelligence chatbots. And a good example of one is Character.ai. And they're getting sued right now by a couple of families that have had their kids use these character AI chatbots that are mimicking being therapists, and kids that are revealing lots of very personal and very tough experiences to the AI through that software that are talking about potentially diagnosable mental health issues as well, and getting back from that AI software essentially that's mimicking a human being and sounding like a therapist, a lot of negative messages that some parents have now stepped forward to create lawsuits around, because the negative messages from the chatbot are saying things like, "You sounds like your family has done a lot of horrible things to you for a very long time," things like that are pretty disturbing to hear their kids hearing about. I also put a quote up here that I'll just spend a second highlighting too, from Dr. Evans, who's our CEO of the American Psychological Association, who and our APA has been taking a stand on some of these things that are really trying to mimic therapists. And in his words, allowing the unchecked proliferation of unregulated AI-enabled apps such as Character AI, which includes misrepresentations by chatbots, is not only being human, but being qualified licensed professionals such as psychologists, seems to fit squarely within the mission of the FTC to protect against deceptive practices. So I think this is really concerning. We really don't know how to regulate these things and take action fast enough, and harm is now starting to really emerge from some of these things. So that's something to be aware of. I want to spend some time too helping you guys understand what prescription digital therapeutics look like. You'll see that in this acronym of PDTs. You'll also see other acronyms that I'll cover in a second. I think that'll come up on another slide for what these are called. But basically, the thing that really just makes these PDTs distinctly different from the health and wellness app, so that first box and that second box, are that these PDTs have rigorously been studied for safety and efficacy in randomized controlled trials, which are the gold standard, as many of you know, for how we look at good evidence base for new interventions. They've been cleared by the FDA, and now they can be prescribed by healthcare providers as regulated by FDA, which also means we're starting to move into the world of having codes to be able to bill for that, although those are very nascent and not necessarily quite yet being used in practice to get payers, insurance companies, to pay for some of this device, quote unquote, use for these digital therapeutics. There is a website I want to highlight to you that the American Psychiatric Association has put together that they call the App Advisor. It's still under works, but it's been released out there. It's meant to be a help to anybody and everybody. It's a public website available to all to give you some education on how to go about assessing whether an app seems good, so to speak. And so what you'll see is really lovely education there around what are the different kinds of features and things around an app that you should be aware of and be evaluating for when you're thinking about either using an app personally for yourselves. As I said, we have a lot of well-being issues within the workforce. We all can certainly use that as well, but certainly before you're recommending or bringing that into the clinical space, that might be a helpful guide to help you tool up in how you look at these things, because obviously this stuff is moving so lightning fast, and we don't have these kinds of skills built into our education programs, let alone in our current workforce, in continuing education kinds of spaces. Another resource to give you all is there's the Digital Therapeutic Alliance is a nonprofit that allows different companies to register for a product library, and they do some vetting of that. So I'm giving you a snapshot of what some of their pages look like in terms of looking at current. And DTX is the other term I wanted to give you, sort of like the other acronym I just shared, but that's Digital Therapeutics. So if you see DTX out there in the world, that's what that signifies. Again, that's a term that's being regulated by the FDA. And so what you can see here is a smattering of a bunch of different potential digital therapeutics that are out there. And you can also see, which I think is super interesting, to look at how there's different health companies out there that are leading the way and trying to put these into play. There's some great products that support opiate use disorder, insomnia, depression, and various others. So you can learn more through that particular website too. What I'm going to say is we don't have a great space that encapsulates all of the digital therapeutics FDA has put together except their own website, which I find incredibly unfriendly. It's got hundreds of digital therapeutics listed, but a lot of those are radiology related, so not necessarily relevant to the behavioral health space. So it's very difficult to filter, to go through all of those in a very easy way. But FDA does have a public-facing website you can search as well. Okay, so I'm going to say a little bit about, if you're not sold yet that this is relevant to your practice, why should you be? So if you're somebody where money talks and sort of watching the landscape, I'm going to give you a little bit of information about that. So this was a report out that I found that I thought would be useful to share, that the projected global digital health market has been growing exponentially, and in 2025 is expected to reach over $657 billion this year going into this market. It's also really important to contextualize that by saying, even though we have hundreds of thousands of digital health apps out there, back when this report, if you go to this link here, is showing 83% or fewer had less than 5,000 downloads. And in the world of downloads, that is teeny, teeny, tiny. Interestingly, though, also over 3/4 of adults actually do turn to digital devices for health-related information. And maybe even more interesting is that over half of all teens, when they were polled in 2022, at least, and so it's probably gone up at this point, have actually used a health app. So kids are very interested in being able to have immediate access on their phones and live in that way through these devices, and potentially could get helped in that way. And then also interestingly, only 2 in 5 of the physicians that got polled said, and this was back in 2022, this is changing now, I think, have said that they want to be able to use AI in practice. I'm getting to almost the end here where we'll move into announcements and questions. But I want to say I'm also partnering up right now and leading the research with our operational leadership to roll out a documentation-focused AI solution. What I mean by that is it's a software that writes the notes for our primary care providers and our other physicians. Right now is where we're starting with, and we're running a pilot across primary care and some other specialty care settings to look at whether getting your notes taken by AI actually improves a bunch of things, including provider well-being, as well as all the kinds of return on investment efficiencies that, of course, our health system is hoping for. So that's been really interesting. And I think, this reluctance that physicians in that group might feel quite differently now. But at this time, only a couple of years ago, the reluctance was pretty low. So I do think that's something we need to keep an eye on. And then this was another summary that I thought I would show you on the right side. And this was back in 2021. So it's a little outdated, and it's interesting that it's really hard for me to find a newer updated one. I've searched high and low. So if any of you do find one, put it in the chat. I'd love to see it. But it does give you kind of a smattering of different apps that have been addressing various different areas that have been down that road of digital therapeutics, either through FDA or over in the UK through approvals there as well. And so when you look at that whole circle and just kind of let your eye rotate around of what those are addressing, it's fascinating to see that the vast majority of these, again, are in the behavioral health space, as I said. But at the same time, to contextualize this, there was one paper in Nature that I've got cited some facts from on the left here, where 829 digital health validation studies were looked at, and less than half of them had an N that was less than 100 people. So these are tiny little studies. We are really only in the beginning stages of trying to do science on a lot of these to see what really works. And yet we also have a lot of dissemination barriers that also need to get addressed. The fact that we have a flooding of all of these types of apps out there, varying functionality and complexity, varying levels of impact, varying levels of cost, right? So all these are really big challenges. This is just a fun picture slide to show you some of the top running digital therapeutics out there that you all might find interesting. I'm not going to go through each and every one of them, but you can see they all have pretty marketing. They're all tied to for-profit companies in various ways. The purple one on the bottom is an interesting example of one that tackles nightmares and PTSD. They sort of hit all these different areas in fun ways and have a lot of marketing push behind them. And I want to say, just to kind of keep it simple for our group, give you sort of this is Kari's sense of what do these digital therapeutics tend to come in and do. So many of them claim that they're retraining the brain, retraining muscles in the body, retraining the nervous system. They're sort of self-initiated but app-guided ways in many instances for the way you can walk through various, whether cognitive exercises, brain exercises, or physical exercises, or both. Many of them offer psychotherapy and biofeedback in various digital formats that include not just apps, but virtual reality and wearables that help support that. I mentioned that purple one on the previous slide. It's actually an Apple Watch that you put on your arm when you're sleeping if you get nightmares from PTSD, and it'll vibrate enough to kind of wake you up before you get into the peak of that nightmare, but doesn't wake you up all the way. That's their claim. A lot of these are being being pushed forward from a strategic standpoint by these companies to be pushed to the market as adjunctive support to medications. So that's also interesting because the evidence base for some of these is nascent and also in that lower range of effect size, which means they may not stand alone as a solo intervention, many of them. Some of them are certainly pushing the direction where they can, and I do think those will probably be emerging more going forward. But a lot of these right now are being pushed as, for example, for those that might be treatment resistant and have tried multiple medications for depression, some of these depression apps might be an adjunctive option to help increase the effect of treatment overall. A lot of these promote lifestyle changes that help manage taking medications, help the body move, help patients track on things. So if you go back to integrated behavioral health, care management is a very active component of integrated behavioral health and primary care. And so some of these apps help with that as well and provide more structure. So it's not just me and my patient talking about that, whether I might see them every couple of weeks, but actually having some support digitally that also could potentially target the kinds of things I might be working on. And then there's video games also emerging. There was one over a decade ago that was actually a video game for teens for depression that showed in that study that video game had 7 levels to it. You pick an avatar, and what you're shooting down in that game are negative thoughts. And you complete those 7 levels. And what that study, a couple of studies found is that in that video game, the kids finished the video game levels faster than they finished CBT with their therapist, which was the gold standard they were comparing to. They were more likely to complete all the levels than they were CBT. They tended to respond faster and stronger, so had better improvements too when they did the video game. So kind of fascinating for us to think about how we can reach patients in different formats using the same kind of evidence-based intervention that we know can work. So that's pretty cool. And more. So this is just kind of off the top of Kari's head as I've been looking at all these different apps in various ways and trying to study them and think about how we can prepare the workforce. I want to highlight, and I've kind of mentioned this before, there's a nice systematic review and meta-analysis that was done that this comes from, but just highlight that the evidence base is in its infancy. There's very little limited precision in not just defining, but also how to evaluate the features of these digital therapeutics. And largely, there's equivocal results with modest effect sizes, as I mentioned. So I'm just sort of repeating what I said before, but in a little more structured way to you guys right now. And there's, at this point, this paper was from 2019, so, things are changing, but you saw me give a little more current up to date. We haven't gotten that far in the last few years. An inadequate evidence base to consider app-based therapeutics as a broad standalone treatment intervention, as I mentioned. Part of this is it's hard to find funding for this kind of research, even though the markets are expanding like wildfire. There was a nice study also published back in 2019 that looked at real world app usage, and I don't think this has really changed very much. What you see at the bottom are number of days from installation for a person on their phone, for example. And so this x-axis, if you can't read that, it's kind of small. It goes from 1 to 30, so about a month's worth of time. And you see really heavy usage happening, of course, as a novel app on your phone in that first week or two, and then it really peters off. And I'd say we've gotten better at this to make that curve a little less drastic. And so, but it still does peter off really in that 1 month window. So you see many of these products sized to be in that 4 to 6 week window of expectation that people are really going to stay and use it. So we have a problem with kind of keeping people in apps, interestingly, not the problem that TikTok has, so to speak. We also have seen some studies coming out now, and this was 2024, so I'm getting a little more into the very recent literature where patients find these kinds of digital mental health interventions really high in acceptability, which is pretty cool. There were 143 articles in this review, and they found 87% of those indicated that patients who use these apps had really positive acceptability for them. So patients do like them. They do want this kind of tooling, potentially, is how I read that. And then there's another review that came out in 2024 that shows there's huge promise growing, but there are barriers too. So while we have this high potential to really improve quality of life, that's what this meta analysis found across 28 studies. The barriers that we really need to be thinking about are the high development costs. That's what the companies are facing, and technical difficulties. They're having a hard time monetizing these. But also there is traditional resistance from the medical community and attitudes of the patients and medical personnel. So I'm here trying to help make that barrier better and get you guys convinced that we need to pay attention to the space and figure out how to embrace it so that it's done the right way, both for us, but mainly for our patients. And there are needs that they highlighted in this review as well, where we really need effective integration with existing medical systems and improve our understanding through all of our medical folks and through our training programs, and have more cost-effective models to be able to put these into practice. Another exciting piece in the literature that's come out is there's been some thinking going on about how to actually integrate them into clinical practice. That's sort of where I sit, where I'm interested in building more grant proposals and studies, is to look at how do we really prepare the workforce in the right way to embrace this. Our providers know how to order labs. They know how to prescribe medications. They have no idea how to prescribe digital therapeutics to people or how to track on them. So this was an example of a paper, for those that might be interested, that kind of lists out systematically what the workflow components are, drawing back to that framework that I published way back and showed you, to those 25 processes and 9 structures. So we have to look at workflow components of what would we really need to change to put this into practice. So it was neat to see that some folks are publishing around that. And then I'm going to end and turn this over to Kari for announcements, and then to everyone else for questions. This is my takeaway, and also what I dream of in my head while I weather all the stressors of the day to arrive on a beach like this at some point. And so I want to leave you all with this positivity about this, that if we can be taking this practice-centric approach in our practice settings and really embrace a lot of the AI and tech solutions that we know are good enough to be pushing forward to our patients, that we can tackle this human barrier issue in the workforce, as well as a lot of the well-being issues that we have. So if we can all go to the beach together, that would be great, rather than drown in the wave that I talked about earlier. So thank you very much. This is fantastic to get to be here. I feel really privileged. Okay. I don't know the best way to tackle that, Kara. Do you have any suggestions for where to begin here? I did see one that was about data privacy that I imagine is a global question a lot of people have. So I'm happy to start with that while we sort of think
Okay.
through what else to address.
Yeah.
This came up, it comes up every time I talk about this, and people's concerns about data privacy. So, I'm not an expert, like I say, in all of these things, although I will say I'm an informaticist. I do a ton with data sharing, data use agreements, and operate in that space as well, just from the university and research perspective side. Be cautious is the thing. I'm gonna say the 23andMe example, that many of you are aware of that company, where you take a cheek swab and it catalogs your entire DNA, and that company recently has gone under, right? And people that have gone to 23andMe have given their DNA over to that company, and when companies go under, they want to monetize whatever assets they can, including your data. So you need to read the fine print on all of these kinds of digital therapeutics. And I think that's where regulation comes into play as well, if there's risk or harms of things, and why I really emphasized in this talk the digital therapeutics end of the spectrum of these things. Otherwise, we really need to psychoeducate our patients around the fact that companies are getting their data in various ways, and you need to be thoughtful about what data you might be agreeing to share when you download these apps, and then what could happen in worst case scenario if the company goes under or they want to sell that. And they are bound to the agreement that you signed, but they also might misbehave, and it might be difficult to catch them for doing that. So that is definitely a fear that's grounded in reality right now, and why Congress is meeting about that on the regular to try to figure out how to regulate.
Maybe a quick one that you can answer. What was the app that Dr. Stephens used in the study for addressing chronic pain that used ACT and CBT? Do you know that one off the top of your head?
I do know it off the top of my head. I'm going to actually not announce that in this big giant group just because I didn't ask the president of the company. It's not too
Okay.
hard to look up and sort of figure out, so to speak, and it'll be in my slides, potentially. So it's not like I'm trying to totally disclose, but I will say, they are not yet in a regulated space on that. They do have an app that I'm happy to mention is on the Department of Health website for smoking cessation. So if you go to that website, that's an app that I can kind of comfortably say is sort of out there for prime time and has a good efficacy trial behind it that a colleague of mine, Jonathan Bricker over at the Hutch, led to really show that helps people with smoking cessation. But I don't want to get ahead of myself and endorse a product that doesn't necessarily have an efficacy trial yet.
Good point.
Yeah.
Do you believe insurances will begin to cover digital resources like this?
Yes, I absolutely do. They actually have to some degree. There are codes now that are out there that do allow for paying for that. What I haven't gotten confirmed is whether those codes are being used yet with the payers. But yes, I think the payers are all deep in preparing for this potentially. Many of these apps are priced right now in direct to consumer routes as $50 per person for an episode of care, and they often get restricted, so you use them in the weeks that it's open to you and then sort of shuts down in that regard.
Okay.
Yeah.
Are there any apps that professionals can utilize with their clients in real time to connect with our clients in an ethical way?
Those are growing. We're trying. Actually, I was just talking with a colleague at Rand about that right before this presentation today. Apps that we're developing out there that are federally funded, that we're trying to integrate into Epic, which, as many of you may know, is a big software company that supports electronic health record systems. So how do we offer securely through electronic health records, through patient portals, more app functionality for people to connect in? So there's some work being done there to try to improve capturing measurement, doing more monitoring of what's going on, and then can we get some of these digital therapeutics into that space too? It's a little bit of competition between the for-profit EHR companies, the companies trying to do the digital therapeutics, the health systems that are trying to protect patients and not have to pay an arm and a leg. So there's a lot of things to work out, but I think, if I had my druthers in the next 1 to 5 years, we will see those kinds of app solutions being integrated with the EHR. So we got to get ready.
Yeah, it reminds me of the sort of pathway that telehealth has taken in general. So, has the acceptability data been broken out by age? I assume that these apps are more acceptable to younger patients.
That's a good question, and I can't speak super educated from total data on that, which is where I'm the most comfortable to be able to do. But if I had to put my money on the table, I'd actually say I that's not necessarily true. We have a lot of older adults that are using these kinds of apps and liking it, and we have a lot of older adults now that have smartphones and are figuring out how how to use them in various ways. So I wouldn't necessarily say, but I do think there are absolutely generational differences in what people's expectations are. Just like I have 3 kids, that 2 in college and 1 in high school, you know, and they yell at me if I text them with periods, punctuation, because they think I'm yelling at them. And I'm thinking that's a sentence. No, I do it. I'm Generation X in my 50s. So, you know, it depends on what people's expectations are. And our phones are a very private space in a lot of ways. And we do need to think about that. How do we customize these so they sort of fit for use for people? But I wouldn't want to say they're only for younger people.
Yeah. Okay, great. I guess this maybe can be the last question we have time for. How can we make sure that AI is appropriate and doesn't negatively impact patients the way character AI has? Is this left up to developers of these apps and software?
Yeah, I mean, I think that's a bit of what I've been trying to get at through this talk, is that we're behind on regulation that would really do that. And I think at all levels, from data sharing to looking at the way that the AI is instantiated. And when you say AI, I mean, that's a specific kind of technology. And I like to sort of put AI in lay terms to say AI is really software that does a lot of math, that creates a very sophisticated but still simple correlation of things. And for those of us that look at statistics, correlation is not causal. It does not say this leads to this. It says this is associated with that. And that is inherently then the flaw of AI, is it's not perfect. It does not give precise information. So how we need to govern that when it comes to mimicking humans and how we communicate. Like, one of the things I worry about is, as AI gets better at showing quote unquote empathy, that a human wouldn't tell the difference between and say, yeah, that looked like an empathic person, is jading the community to then actually get allergic to empathy related behavior because they're going, well, that might be a fake AI doing that. Humans are
Yeah.
smart. We learn to not trust things too. So I think there's dangers in how we move forward with these technologies, even though, you know, a lot of the young workforce in software development are super excited about it and like to cancel culture, say we don't need primary care anymore. You know, we can just have an app diagnosis. We need to be really careful about the dangers of it. So I don't have a great answer except to say we have a lot of work to do to regulate the dangers, and we tend to be a reactive, litigious society. So until someone's hurt, we don't usually see the best response yet. Is sort of my 2 cents, unfortunately.
Yeah. Well, thank you, Kari. Again, this was such a great talk. Really, lots of thought-provoking stuff that you brought forth, and like I said, you know, more to come. We hope on this topic in the.
Feels good, everybody. Thank you so much. Yeah, really an honor to be here. Appreciate
Yeah.
it.
Thanks so much. Bye bye, everyone.
Bye, everyone.